Okay. Imaging of paranasal sinuses, basically CT scan, is one of the most frequently performed examination. And the common pathologies that one look at or image for is sinusitis and polyps. Comparative to the sinusitis and polyposis in paranasal sinus or compared to head neck tumors, paranasal sinus or sinonasal tumors are not common. They're relatively uncommon. Many of these tumors have non-specific presenting symptoms and imaging features. However, some can help to narrow the differential diagnosis. Now, an important thing is that paranasal sinus has got a diverse histology. It has got ectoderm, mesoderm, that is all the cells, dermal cells, glandular cells, vessels, cartilage, bone. So large variety of neoplasm can occur in this region. So let's see some cases, some tumor-like cases mimics their characteristics and some less common lesions. Now, histological classification being like everywhere else is benign and malignant. So epithelial tumors like papillomas, soft tissue tumors like hemangiomas, angiofibromas, bone and cartilaginous tumors like fibrous dysplasias and osteomas, hematolymphoid tumors, neuroectodermal tumors, germ cell tumors. Their malignant counterparts are squamous cell CAs, adeno-CA, undifferentiated CA, the soft tissue and bone malignant tumors being the muscle, the rhabdomyosarcoma, the bone, the osteosarcoma, lymphoma, plasmacytoma, etc. So again, there are certain mimics which can come as tumors. Now, just a slide on WHO classification of tumors of nasal cavity and paranasal sinus and skull base, the 4th edition in 2017. Several new entities and provisional entities were added to the chapter of nasal cavity, PNS and skull base, which includes HPV-related multiphenotypic sinonasal carcinoma, the SMARCB1 deficient sinonasal carcinoma, the renal cell-like adeno-CA, seromucinous hamartomas, the nut carcinoma, biophenotypic sinonasal sarcoma. So this has been the newer edition, which is the 4th edition in 2017. Now, let's go on to how my talk is going to be. It is going to relate to what kind of symptoms the patient comes with. So it is a very practical approach to what you get in forms of patient. Most of the patient comes with nasal block, epistaxis, pain, and swelling. Let's start with nasal block. An 18-year-old male, nasal block, breathing difficulty, and on examination, this is what the ENT surgeon can see. There was a lesion in the anterior naves. Beyond that, the ENT surgeon could not see. Mind you, 18-year-old male. I'll just take two laser pointer. Okay. So these are all plain images, axial and coronal. You have a soft tissue density lesion occupying the entire nasal cavity, peeping via the posterior choana into, that is what it is seen, and into the nasopharynx. And if you go in the axial, you'll appreciate that this area is very important. This is the sphenopalatine foramen, pterygopalatine fossa, and laterally is the pterygomaxillary fissure. So a large tumor or a lesion, soft tissue density occupying the nasal cavity, displacing the nasal septum to the opposite side, that is to the right. And as you go behind, you will see the posterior choana. It is causing kind of abutting the hard palate. We'll see bone window what happens. And this is the area of the pterygopalatine fossa. The bone window will show that the pterygoid plate is partially eroded. Let's see what happens on the coronal and sagittal image. We'll appreciate that there is widening of the superior and inferior orbital fissure. You can actually see the widening of the pterygopalatine fossa very well. On post-contrast study, you'll see avidly or intense enhancement of the lesion, which was seen in the nasal cavity. And so the epicenter of this lesion is in the sphenopalatine foramen and pterygopalatine fossa. Now, as a radiologist, your job is to identify where it has extended. Like in here, it is Nasopharynx, it is gone into the, reaching up to the anterior nares where it was seen. Here, unfortunately, this patient has an intracranial extension in the parasalar or medial temporal region, extra-axial, mind you. So the moment the lesion reaches this area, that is intracranial, things get little complicated. They call it as a red flag, because this patient may require, before treatment, radiation. Coronal image not only shows you the lesion, it shows you how it is extended, its extension into the sphenoid sinus and intracranially. And this is the infratemporal extension. And on sagittal image, it shows you that the lesion from the anterior nair to the posterior choana and into the nasopharynx, not extending into the oropharynx in this, and it is involving the entire ethmoid air cells and the sphenoid sinus. By now, you already know what this lesion is. It's a juvenile nasopharyngeal angiofibroma. And delayed images just done if you want to go inferiorly. Here, you don't expect any internal jugular vein thrombosis. Now, the usual supply to this is internal maxillary artery. Now, what next? What is the role of the radiologist? Now, in comes the role of an interventional radiologist. Is the embolization, and the embolizing material is PVA particles, and it is 250 to 300 microns. And when is the embolization done? Basically, whenever they plan the surgery has to be done 48 to 72 hours. So not before 48 hours and not after 72 hours of embolization. And in our institute, we do per week 1 embolization for JNA. It's a very high JNA institute. So this is one case where we are seeing that there is a pre-embolization. You can see the blush. This is selective catheterization of internal maxillary artery, and the catheter is gone beyond that, and you can see that there is a blush. And after PVA particle, you will see that it is completely embolized. Mind you, before embolization, one has to see where that, hopefully that there are no feeders from internal carotid artery, especially in tumors which have an intracranial extension. Now, one should also know how a post-operative CT in a post-operated for JNA looks. Like in this, they have removed the nasal septum. They have made a large kind of a window in the region of sinonasal cavity. You cannot identify the normal anatomy of the maxillary sinus, nasal septum, or the turbinate. So whenever you see this kind of appearance, go and ask what, even if the patient is older, go and ask the history whether the patient was operated for JNA, because the kind of resection done for JNA is quite extensive. Now, all of you already know that it's an exclusively lesion occurring or tumor occurring in males, usually in adolescents, but I have seen cases as young as 8 years and as late as 28 years. It's one of the benign tumor. Its location, as I've already told you, spinopalatine foramen, pterygopalatine fossa, and its extension is very important. That is what, as a diagnostic radiologist, is where exactly it is extending. Basically, once it enters the infratemporal fossa, its extension into the other areas, and also extension, if there is extension to the orbit and intracranial cavity. Now, there are certain signs that one should be aware when there is JNA. One is bowing of the posterior wall of the maxillary sinus, called as Holman-Miller sign. Then extension of the lesion into the pterygoid wedge. So if you see, this is the pterygoid bone, and the lesion extends into the pterygoid wedge. Like here, the lesion is extending into the pterygoid wedge. This is the medial pterygoid plate, this is the lateral pterygoid plate, and the lesion is extending into the wedge of the pterygoid. That is a Ram-Haran sign. And what is the Hondosa sign? Hondosa sign is the widening of the gap between the ramus of the mandible. This is the ramus of the mandible and maxillary body. So this gap is widened as compared to this. So in this patient, there is the Ram-Haran sign, And in this patient, apart from Bramharan sign, there is also Mendoza sign. Another similar case, but not that extensively involving spreading. Same 15-year-old, so adolescent male with epistaxis. You have a soft tissue density lesion in the spinopalatine foramen, pterygopalatine fossa, in the nasopharynx posterior choana, as you can see in the coronal. And here on the bone window, you can see the lesion extending into the wedge of the pterygoid plate. This is a nicely corticated normal pterygoid wedge, and see there is cortical defect. So again, the Bramharan sign. Post-contrast study, you will see that there is moderate enhancement and the lesion is partially extending to wedge of the pterygoid plate. So this is a smaller tumor as compared to the first one. And what this sagittal image shows, that the lesion is involving the extending and causing widening of the pterygomaxillary fissure. So this is another case of JNA. Now, another case, another pathology. Patient presented now with epistaxis. Axial image, plain coronal, anterior most part where you are not seeing the turbinate. So there is an oval soft tissue density lesion in the left side of the nasal cavity, abutting the nasal septum as well as the lateral cartilaginous portion of the nasal wall. What next? Stop here or do CCT? Yes, you're going to do CCT. Our example, this thing is tumors and mimics. We are going to do contrast enhanced CT scans. So what do you find here? You have an heterogeneously enhancing oval lesion, which was what I showed you on plane. It is heterogeneously and partially avidly enhancing lesion. I don't know whether you can see, but this is 112 and this was 32. So avidly enhancing but heterogeneously enhancing, and the sagittal image shows that the lesion is not abutting the inferior turbinate. It is just abutting the nasal septum medially and anteriorly the undersurface of the lateral wall of the nasal cartilaginous portion of the nose. So diagnosis, adenomatous nasal polyp versus angioma. It turned out to be hemangioma. What are the types of hemangiomas? Capillary and cavernous. Capillary are lobulated, are composed of capillary-sized vessels lined by flattened epithelium. Basically, these hemangiomas can occur in all ages. They peak in children and adolescent males. They are commoner in females in their reproductive age, and beyond the 5th decade, male and female are equally affected. Cavernous hemangiomas are usually large, inhomogeneous mass with heterogeneous enhancement of either centripetal or multifocal nodular pattern. You can do an MRI with it with biphasic contrast injection. Another case, intermittent episodes of epistaxis in 3 months. And on examination, of course, ENT surgeon could see a anterior nasal cavity lesion on the left side again. So here the lesion is not exactly in the anterior nares, but mildly posteriorly, again attached to the nasal septum. This lesion has lower density than the first one, 12.8, and post contrast, it is really avidly enhancing to 160, more intensely enhancing than the previous lesion. So as you can see, there is heterogeneous avid enhancement seen in the lesion located in the left nasal cavity, abutting here the inferior turbinate and also the nasal cavity. And it is not abutting the floor of the nasal cavity. The sagittal images shows that the lesion is arising from the inferior turbinate, from the middle turbinate and abutting the inferior turbinate. So actually you are not able to see the middle and inferior turbinate anatomy very well on the anterior aspect of the turbinate or nasal cavity. And on sagittal images, you will see the lesion arising from the middle turbinate under surface, and this is the inferior turbinate. So point here I am trying to tell you is always look at the sagittal image. You tend to look only at the coronal and at the most axial, but definitely look at the sagittal image, which will give you an idea where the lesion is arising from. Just the delayed images. So this turned out to be a LCH, not Langerhans cell histiocytosis, but lobular capillary hemangioma. So what do you look at? Now, if you look for presence of bone destruction, if the lesion is rapidly growing. So usually these lesions do not cause bony destruction, but if they are rapidly growing, definitely they cause bony destruction. And if the lesion is from at the roof of the nasal cavity, like this lesion, what at the middle turbinate, so the mid and inferior part of the nasal cavity, but a similar lesion at the roof of the nasal cavity, then look for any intracranial extension. Another patient, a 43-year-old male, presented with swelling over the cheek. So from nasal blockage to epistaxis, we have come to another symptomatology where swelling and is a non-diabetic. I purposely said non-diabetic because we saw a lot of mucor. Non-diabetic, non-COVID, a 43-year-old patient with cheek swelling. Now, these are MRI images. What do you have in MRI? The T2 weighted images shows a kind of, I'm using a specific term called gyriform or cerebriform pattern of lesion, which is T2 hyperintense, but not as hyperintense as sinusitis would be, but it with areas of linear areas of hypointensity on T2. On T1, it is definitely isointense to the muscle. Now, apart from that, you have to tell about the location. So this lesion is located in the nasal cavity on the left side, extending into the maxillary sinus, beyond the maxillary sinus in the posterior retromaxillary area, and on the coronal image, you can say a large infratemporal extension, and you can see a large intraorbital extension. It is not restricted on DWI and not low on ADC. The axial image, the stack images of the shown, same patient shows the intranasal lesion in the left side, middle turbinate anatomy not seen, intraorbital extension, so on and so forth. Maxillary sinus here is normal. You can't appreciate the maxillary sinus, and a large premaxillary infraorbital component, which is what the patient presented with. Post contrast images shows the proptosis, intraorbital, extra as well as intracoronal extension. And just to show you that the lesion abuts the inferior turbinate, middle turbinate normal, abnormal side is not seen. The bone window, the CT scan, basically I want to show you the bone window. There is erosion of the medial wall of the maxillary sinus, anterior wall, posterior wall, and this is a heterogeneously enhancing lesion with a large premaxillary component. Sagittal image shows you the intraorbital. Now here, this is more extracornal compartment because you can see the inferior rectus elevated. This is the optic nerve, and here you cannot identify the inferior rectus muscle, and you can see erosions of the lateral wall as well. So this turned out to be inverted papilloma called as IPAP. They are most frequently encountered benign epithelial neoplasm, and IPAP is the most common subtype. Why is it called inverted papilloma? Because it's got an endophytic growth pattern. Usually presents between 5th through 7th decade. IPAP is more common in men than women. I already told you it has got the MRI showed the cribriform pattern or columnar pattern, characteristic for IPAP. CT delineates bony remodeling, focal erosion, and may show bone strut or focal hyperostosis at the point of attachment of the lesion. Now, if the destruction of the bone is too much, you can say it is IPAP with suspicion of malignant transformation. Now, it is important to report the site of attachments as complete resection is required to prevent resection. Foci of necrosis, of disruption of the architecture, or as I showed you, severe destruction of bone, you should raise suspicion of coexistent tumor. So the final diagnosis in this case was IPAP with malignant transformation with coexistent squamous cell carcinoma. Now this patient, a 72-year-old next patient, mass in the buccal cavity, right nasal cavity, and had a histological proven Schneiderian papilloma. What is Schneiderian papilloma? Also called as sinonasal papilloma, considered as benign sinonasal tumor arising from Schneiderian epithelium. Now, IPAP is most common subtype of this Schneiderian epithelium. The other epithelial malignancy or papilloma. The other one being exophytic papilloma, and the third one being oncocytic. Now, this is a 72-year-old patient. You will see this plain CT scan shows a large component in the nasal cavity from the anterior nair to the posterior nair with erosion of the hard palate and extension of the lesion, or on the plain CT, we don't know whether this is a extension of a lesion or sinusitis, because you can see the density of this is different from the medial and anteromedial component of the maxillary sinus. This is sinusitis, and this probably is the invasion of the mass. Also anteriorly, it is causing erosion of the maxillary alveolus. Bone window shows extensive destruction of the maxillary alveolus, also of the hard palate, so on and so forth. This is post-contrast image showing you heterogeneous moderate post-contrast enhancement of the lesion and its extension. The coronal images also shows that there is an intraoral component of the lesion, and you can measure the intraoral component from anterior to the posterior aspect, and there is severe erosion of the hard palate. So maxillary sinus, nasal cavity, intraoral component. The previous CT showed the lesion, but remember, there was no nasal component. And of course, the previous CT was from outside and they have not done open mouth view. Now, if you see the difference, this is the previous CT, this is the current CT. You will see that the open mouth view showed the intraoral component very well. The closed mouth cannot really appreciate the intraoral component. Also, if you compare, there is growth of the lesion. So there is involvement of the anterior nares and complete obstruction of the anterior nair as well as the nasal cavity. So if you have always, in cases of tumors, try to understand and ask the patient if there is a previous CT. In this patient, there is definite increase in the size of the lesion and increased extension. Coming to another pathology where there is an soft tissue density lesion with erosions of the walls of the maxillary sinus. You can't really see medial wall, inferior wall, the hard palate. It looked like the previous case. This is nothing but malignancy. Now, squamous cell carcinoma, what are the CT features? Is prominent bone destruction. And MRI, what are the MRI findings? It is the intermediate T1 signal intensity, hypointense on T2 as compared to fluid. Because remember, the fluid, which is non-fungal, of course, non-fungal infection, just sinusitis, is very bright on T2. So these lesions are less than that of the fluid. Most squamous cell carcinoma have a non-specific imaging appearance. So let's go on to see some cases. Again, if you remember the first case I showed you, the nasopharyngeal angiofibroma, it had a nasal component, but look at this. This is not widened. That is a sphenopalatine foramen and pterygopalatine fossa is not widened. The lesion looks the same, but the key factor is here. The lesion is extending into the maxillary sinus, and in the JNA, there was not much lesion that we saw. Of course, you can get, but not very common. So this is anterior periantral extension of the lesion. Of course, there is intra-orbital extension also. Post-contrast shows heterogeneous moderate enhancing lesion involving not only of the nasal cavity like here, maxillary sinus, ethmoid air cell, and intraorbital extension and causing retention sinusitis. You can see the intraorbital extension. Extensive bony erosions. I will just quickly show you. I've finished my 25 minutes. I had kept an alarm. So you can see that extension of the lesion in the nasal cavity as well as the maxillary sinus, the ethmoid sinus. This is the medial rectus, so extracornal extension, so on and so forth. So a higher age group, extensive involvement of the structure adjacent to the nasal cavity and paranasal sinus with bony destruction, like you're going to see here, lamina papricea, the roof of the maxillary sinus, medial wall, the ethmoid trabeculae, and as you go posteriorly, the lesion is also causing partial extension and erosion of the lateral recess of the sphenoid sinus. So keep in mind the age of the patient and erosions of the bone. This was a sinonasal carcinoma. So antral or maxillary sinus carcinoma are uncommon head, face, neck tumor, average age being 45, more common in males than females, almost 5:1. Despite large lesion, but it is confined to the maxillary sinus. Hence, the symptoms are quite late. Another patient, female here, proptosis, left eye with diminution of vision, associated pain and left nasal discharge. Again, the findings are similar. Expansile lesion in the nasal cavity with intraorbital extension, moderate heterogeneous enhancing lesion, severe bony destruction, but the age is higher. Also, the fovea ethmoidalis is eroded, so is the anterior part at where your Kiros classification. Remember, the cribriform plate is eroded. Presence of a soft tissue in the nasal cavity. As of now, there is not any intracranial extension. Again, a sinonasal carcinoma. We went ahead and did the MRI. T1, it is iso-intense. On T2, it is hyper-intense, but not as much as the maxillary sinusitis. So this is retention sinusitis, and this is extension of the lesion into the maxillary sinus. This is extracornal extension of the lesion. T2, it is hyperintense. On diffusion, it is restricted with low ADC value. Post contrast, it shows heterogeneous enhancement. So both are CT and MRI cross-sectional imaging showing you the extension, and here it is also extending to the supraorbital air cell, but there is no intracranial extension. A sinonasal carcinoma was given, and the histopathology came as adenoid cystic carcinomas. They are very rare tumor. Salivary glands are more involved than sinonasal region. And the problem is you cannot really differentiate adenoid cystic carcinoma from a squamous cell carcinoma. Another patient with epistaxis, headache, nasal obstruction. You have a lesion which is now has an intracranial extension along the base of the anterior cranial fossa with erosion of the cribriform plate, fovea ethmoidalis. This turned out to be a esthesioneuroblastoma. So yes, there is a confusion when it comes to ethmoidal cell tumor and esthesioblastoma. I'm not going to read all this because I'm falling short of time. Now this is an 11-month-old, so our age is changing. 11-month-old male, mother noticed a swelling. So again, a soft tissue density lesion in the nasal cavity, extending into the orbit. Lamina papricea is eroded, and it is abutting the medial rectus muscle. On post-contrast study, it shows heterogeneous. Now the age is different. So when you have a child, now this was less than 2 years, and you have a large lesion, which is causing erosion, like here in lamina papricea, normal and abnormal. Think of rhabdomyosarcoma. Common in males, Caucasian children below the age of 15. Types you all know, and a differential diagnosis of lymphoma. Treatment is usually radiotherapy. Now, this is an interesting case. I will quickly go through it. A 65-year-old, histopathologically rhinoscleroma, a debulking surgery was done. We did a CT scan on 13 December 2021. You see, again, a soft tissue density lesion with ethmoid invasion maxillary sinus. This is plain. Let's see what happens on post contrast. And this on bone window shows rarefaction. It is not complete erosion, but rarefaction of the medial wall of the maxillary sinus, posterolateral wall of the maxillary sinus, and also the inferior wall. So there is rarefaction of the lesion. And the current CT also shows that the second CT, that was for us the current CT, shows that this is an enhancing lesion which has got a large preseptal component, and it is abutting the eyeball and has got an anterior nasal cavity component and preentral component. And to our surprise, look at the lesion in the neck. Multiple lymph nodes on the left side, right side, a large lobulated mass causing all the mass effects on the internal carotid artery, the common carotid artery, and this lesion has an intraoral component. So extensive lymphadenopathy. So we told them that kindly revisit and repeat a biopsy, because on imaging it looks like a lymphoma, though it has a rhinoscleroma diagnosis from before, and a repeat biopsy suggested a lymphoma. So lymphoma can occur in sinonasal cavity. Remember, necrosis is uncommon compared to other malignancies in lymphoma. On MRI, it is isointense to other soft tissues on T1 with homogeneous enhancement. A characteristic feature of NHL is hypointense signal on long, that is T2-ated images or STIR sequences. Now, just quickly going to the different spectrum, that is increased bone density. This is ground glass opacity involving the zygoma as well as the maxilla, basically encroaching the maxillary sinus. This is nothing but fibrous dysplasia. One quick example of a 3-year-old child with nasal blockage due to a lesion which they could see in the nasal cavity. The child had a nasal breathing. So axial coronal sagittal plane images shows a hypodense lesion in the nasal cavity which is expanded with displacement of the nasal septum. On contrast study, there is no enhancement, and maybe there is a kind of a defect seen in the level of the cribriform plate. So it went ahead and that did MRI. MRI shows that it's a hypointense lesion in the nasal cavity with few septae. On T2 sagittal and coronal image, you can see hyperintense signal within the lesion, which is involving the anterior nair of the posterior choana. And there is this stalk-like area with a defect which I showed you on the CT scan. We usually don't do flare below the age of 2 years, but in this patient, we did flare to show that this is nothing but CSF because the signals have got suppressed. Post contrast also did not show any enhancement of the lesion per se, but peripherally there was enhancement. And patient was operated for this encephalocele, frontoethmoidal encephalocele. So basically, there are 3 types of frontoethmoidal encephalocele, nasoethmoidal being the most common, which was the case I showed you, nasofrontal being second, and the least common being nasoorbital. Few quick examples of mucoceles. There is complete opacification of the involved paranasal sinus, like in this, the ethmoid paranasal sinus. Pressure erosion of the adjacent bone, like in this patient, here is the lamina papricia erosion, and there is extension of the lesion into adjacent compartments. Like in this is the extraconal compartment of the orbit, causing mass effect on the medial rectus, stretching the optic nerve and also causing proptosis. So basically, it is complete opacification of the paranasal sinus, whichever it is involved. Like here, it is involving a part of the frontal sinus, supraorbital air cell, complete opacification, non-enhancing, pressure erosion, and it is abutting the eyeball. So mucosal, just showing you the bone window that it is pressure erosion. So I've already told you complete opacification, expansion, thinning out or bony resorption, and extension into the adjacent structure. Now hyperdense lesion, like here, this is a bony lesion seen in the ethmoid air cell. This is nothing but an osteoma. What is the importance? Smaller osteomas or the size is important because it can hamper the drainage site. This was a large cartilaginous tumor which is seen in the region, or you can say a hyperdense lesion, expansile lesion seen in the nasal cavity with chondroid matrix and expansion of the nasal cavity. It is not extended into the orbit, neither has it extended into the maxillary sinus, except the osteomeatal unit is compromised, so there is maxillary sinusitis. So this was a chondroid tumor. Some other hyperdense areas in the nasal cavity or in the paranasal sinuses, like in this is a rhinolith, or it could be a foreign body with, if there is no history of foreign body insertion, and this, if you can see, you can safely call it a rhinolith. If something similar is there in the sinus, it can be a sinolith, like in this patient where there is sinusitis with high density area within the opacified maxillary sinus. This is nothing but a sinolith. So before we end, I would like to summarize by saying sinonasal neoplasms are rare, accounting for 3% of head and neck malignancies and 3.6% of upper aerodigestive tracts malignancies in the National Institute of Health Surveillance Epidemiology and End Result Studies. CTR and MRI are complementary modalities. CT diagnoses common pathologies. As regards to neoplasm, location and overall size of such masses and then potential extension into the adjacent lesion. Thus, what is our role is to help them plan their therapy, either surgical resection or at least debulking, if not complete resection, basically to prognosticate and tell the patient what are the chances of their losing the eyesight or losing they have to open up the cranium, because to open up a cranium or the skull and to tell the patient is a very important part of the ENT surgeon, and you should tell, yes, there is a extension into the intracranial. That finishes my lecture. Thank you so much for having me here.
Thank you so much for sharing your knowledge, ma'am. There are no questions in the box yet.
Let me stop sharing. Just go to the arrow. Thank you, Abhishek.
Thank you so much, ma'am. Before we move on to the next session, we have Dr. Patkar stepping in for a quick word.
Thank you, ANAGHA. I think you go back to the match, right?
Yes,
ANAGHA?
I have a